And it's so easy to drop out of your normal routine because you're relaxed. And it's when you drop out of that regular routine that you risk missing things.
Hello, you're listening to the Dental Protection Podcast, and this is the Case Files series where we're looking at diagnostic errors, which are often the drivers for the cases and claims that we deal with for our members. My name is Dr. James Foster. I'm the Deputy Dental Director and Dental Lead for Asia and Australasia. My own background is from general practice and as a trainer for younger dentists and working in the dental school in Newcastle. I joined Dental Protection full-time in 2008, and it's my pleasure to be joined today by my colleague, Dr. Jim Lafferty, who is a part-time general dental practitioner, recently celebrated his 30-year reunion from University of Birmingham, and Jim is a dental legal consultant with Dental Protection since 2016. In 2018, Jim joined me in the international team, where we work with Dr. Lou Eggleton, handling cases for members in Asia. Jim has sat on the UK's General Dental Council for 2 periods of office and has had various senior roles within the British Dental Association, including periods as chairs of the UK Council, English Council and Young Dentist Committee. Welcome, Jim.
Hi, James.
Now, in this episode, we will explore and discuss some of the common dental legal issues arising from diagnostic errors when providing long-term care. How can we ensure a comprehensive approach to diagnosis during the longer-term care of our patient base and avoiding the associated dental legal pitfalls from common omissions? Now, Jim, when we think about long-term care and the potential cases that we may see, there are 2 main areas that jump out. So the 2 areas that spring to mind and become perhaps the most significant in our experience are the areas of implants and periodontal disease. Now, Jim, as we've seen in the UK, there have been many cases arising from the issue of adult chronic periodontitis and not providing appropriate treatment. This has led to claims that as a result of not providing the treatment, patients have lost their teeth, and then the provision of putting them back to where they were before. We appear in this country to have gone down the use of implants. And as that has been going on for some time, we could be looking at a second issue in terms of whether those implants were appropriate in the first place. And that brings into play a little bit of a focus in other countries about what are we seeing with implants? What's happening in the long term? What are the expectations and how do we manage failure? And do you think that's something we're going to see a rise of in the future?
We're already seeing that in some countries. I think inevitably where you've got a treatment that is very high cost to a patient, where complications arise, their expectations are so much higher about how long they perceive that treatment should last. And if it doesn't match that expectation, then we're likely to see complaints to the practice and the practitioner, complaints to the dental council, or even claims for compensation.
And I think, talking of claims, what we saw in the cases that we've had here is when the replacement is provided and the damages, general and special damages are all considered, we used to look at a simple 1 implant replacement for life. With the acceptance that it was a 30-year plus. Now, interestingly, when there is a claim, you will have an expert appointed to talk about causation and the future prognosis. Those experts now are reconfiguring the expectant life of an implant to be more in the region of 10 years. So if we have a patient who is predicted to have another 30 or 40 years of life, we may see 3 cycles being included in the compensation as with crowns, Jim, yeah?
Yep, we're seeing claims set out the life expectancy of a patient as part of that process. So I saw one just yesterday where the expectation with the patient would live another 48 years. And so a periodic replacement of either the crown, an implant retained crown that's sometimes set out, or sometimes the implants themselves. And I don't think experts have yet kind of come to a unified position on how long they ought to last. So we see a little variation in that, but the sums can be quite eye-watering if you can imagine replacing an implant and a crown every 10 years, and there are many of them in a mouth that need doing. So the future damages element of a claim for compensation can have a lot of numbers in there.
So in terms of looking at the long-term care of our patients, when patients have implants, perhaps communication around expectations about potential failure is something that we've seen overlooked a little bit.
Yes, I mean, we're kind of sold to the profession as the answer to everything. And in reality, we see that there's a period immediately after placement when there's a relatively high failure rate, and then another peak around the 9-year mark, depending on the design of the implants themselves. So if a patient doesn't realise that this potentially is not a permanent fixture, then they're going to be upset when it fails.
Yes, and I think that, multifactorial indeed, isn't it, related to the failure, but certainly that it's starting to come down, as we've seen, as evidence with the experts' opinions and reports, and as that continues, I think there will be some more challenges, and I think communication is such a key element, isn't it, in relation to this, which is, as you say, the most expensive form of dentistry that we're seeing.
Yeah, the expectation, if a dentist does something wrong, if they are negligent in their care, then the courts and the legal process, the only way they've got of putting that right is by the payment of compensation. We can't force a patient to go and have treatment because obviously they've got to consent to it. So all remedies are financial. And if you have lost a tooth, then a patient invariably will expect an implant as that replacement, and their claim for compensation will set out the amounts for that, sometimes even if there is another form of treatment that's more appropriate.
And interestingly, the issue about the existence of periodontal disease attracts various different opinions, and obviously we're not carrying out clinical research, we're talking about cases that we see, and there is an area of conflicting views about to place implants in the presence of disease or not, and the risk scale that's associated with that. And I think it's fair to say, Jim, in some cases when we have seen periodontal disease being mentioned in Asia, it is when periodontal disease is present and work is undertaken, and that allegation is that it's compromised from the outset, and the long term is therefore itself compromised.
Yeah, so if you put implants into a mouth with untreated periodontal disease, you have got the right bacteria to cause periimplantitis. Yes, the mechanisms are not identical, but there are so many similarities, and the complication is so well recognised that it's almost impossible to defend the placement of implants where there's untreated periodontal disease.
That's it in essence, isn't it? We are struggling to find experts now to defend a situation where, in the presence of disease, treatment has carried on. Now, in terms of the periodontal disease itself, when we consider that separate to implants, treatment of perio is something in other countries that is very much on the radar. We don't see that many cases in Asia relating purely to periodontal disease, but it may be an area that we see more in the future. And perhaps, how do we manage the situation? How do we manage the perio disease in our patients? Because we come across all sorts of barriers: fees, understanding, actual patient motivation. And what other approaches do you use in your practice, Jim?
So I'm sure everybody listening is familiar with the new categorisation of periodontal disease. So all of the continental periodontal associations produced a series of position statements in 2018 and 2019. And so we've now in effect got redefined classification of periodontal disease, which includes staging and grading. The only way that you're going to get to the point where you have recorded that is if you are doing routine BPEs and, where necessary, doing 6-point pocket charts, bleeding indices, checking for mobility. If you haven't done those and a patient loses teeth from periodontal disease, then the accusation will be that you've failed to assess and you've failed to monitor. And often the the loss of the tooth occurs an awfully long time after that failure to provide the reasonable standard of assessment and monitoring, what we call a long tail case within dental protection, because the manifestation of the damage takes so long to occur.
And whilst we don't see huge numbers of those cases arising at all in Asia, we do have them elsewhere. Members can be assured that the subscriptions they pay in each country are linked to the experience of cases in that country, but we wouldn't want to see this as an area of increasing cases arising. And there are patterns in the way that clinician might manage the situation, and the familiarity trap, Jim, seems one for periodontal disease over the long term.
Yep, so I've been in the same practice for 27 years now, so I'm in the lucky position that with a few families I've seen 4 generations of patient. And where you see somebody routinely, some of those patients I've seen every 3 months for the whole of that time because of their oral hygiene needs and the amount of tartar buildup and because of their periodontal condition. It's very easy to fall into a relaxed state when you see someone that you're familiar with, particularly because they'll be relaxed when they come in, they'll jump in the chair. You'll probably have some unwritten communication with you. You know, they'll be used to your shorthand for where you want to examine them, how when you get them to stick their tongue out. Some of them are doing it almost as they sit down these days with me. And it's so easy to drop out of your normal routine because you're relaxed. And it's when you drop out of that regular routine that you risk missing things.
Indeed. And I think I've experienced in my own practice, when you're seeing someone regularly, there's almost the drift towards an acceptance that the periodontal condition is deteriorating, but we just keep ticking it along. And I think the danger is then that patient, should they ever go to another practice and the stark reality of a new examination and explanation be something that they hadn't realized or perhaps they'd forgotten, and suddenly it looks like the long-term friendship and familiarity you've had is challenged through almost a swing round to "you should have told me this" perception of deceiving them.
Yeah, I had a complaint about 4 years ago from one of my patients who went somewhere else, and one of the complaints was that I had never told them that they had gum disease. Now, fortunately, when I wrote my response back to the patient, I could, and I provided them with a copy of the records. I had been doing BPEs since 1997 from until 2017, which is, I think, when the complaint occurred. So I don't know, there were 30 or 40 records of the monitoring I'd done. I'd done 6-point pocket charting. I had done several rounds of root planing, and in my records I had specifically advised the patient that they'd got gum disease and that if it deteriorated there were risks of losing teeth or loose teeth. So I was able to rebut that complaint, but the risk is if I hadn't taken the time to record that at the time, then I would have been vulnerable because they'd gone to another dentist. And I don't know what it is, James. Is your experience like mine that patients always seem to believe their newest dentist over their previous one?
Yes, it is often the way. There's often a snap back, and the trust that you might have built up with that patient can readily be undermined by the explanation of a new practitioner. I mean, the duty of the new practitioner is to say what they see, and if any concerns are there, then push the patient back to the original treating dentist, which is quite right. And then the opportunity to explain the situation arises, like you obviously described in your own, and we're able to rebut it. There are situations we see where a patient wishes to take control of their own care and their own treatment, and it may be presenting that they refuse to have a particular type of treatment. They may insist on another type of treatment. And just to highlight, we need to be aware of those patients because they're demonstrating behaviors that often indicate those are the patients that will take things further when the outcome isn't as expected or as they wished. So we'd always say keep comprehensive records, and the issue of informed refusal, recording in there should a patient refuse a particular treatment.
Yeah, I have another little anecdote. I've got a lovely old lady patient, and she first came to see me 10 years ago, and I diagnosed advanced periodontal disease at that point, and I offered her root planing under local anaesthetic, and she basically went, "No, not interested." And I said, "Well, Do you realise what the consequences are? And she said, yeah, I'm going to lose some teeth, but I'm not going to live that long. As it happens, she's lived far longer than she anticipated, and she's probably half the number of teeth she had 10 years ago, and she's lost all of her posterior teeth now. But I recorded at the time that I had given advice of what the consequences were of no treatment. And I know in some of my colleagues' cases where they're still using paper records, where treatment is declined, they'll often get a patient to countersign the record to show that they've declined treatment. Because if this lady were to go elsewhere, they'd identify very advanced gum disease, and she's going to lose some more teeth in the next few years.
So, moving on, Jim, we've looked at implants and periodontal disease, so perhaps the two big ticket items. And over the longer term, a couple of other aspects we might wish to consider is maybe tooth wear, failure of dentition, and maybe some TMD with reorganized occlusion. Now, you would have seen patients over the long term from your practice. I understand you've had patients you've been seeing for 20 plus years. Tooth wear, something you're seeing very commonly?
Yeah, there are well-recognised indices of tooth wear. They're worth reviewing. I think this is going to be the next big area of claims in the UK. Certainly one of the big law firms who specialises in dental claims in the UK has started to do an increased number of claims. So are you assessing tooth wear routinely as part of your checkup? Is that tooth wear pathological for their age? And have you had a discussion with the patient about the potential consequences of further tooth wear if they don't address it?
So keeping records, making sure there's clarity and communication are the elements above and beyond the disease itself in terms of risk management.
I mean, there are positives to those discussions as well, in that some of those treatments will be multi-tooth based. They might be reorganized occlusions, might be whole mouth rehabilitations. In the UK, we're far more likely to do that in more reversible procedures, so composite build-ups. We're seeing an awful lot of those at the minute. But yeah, does your patient know that tooth wear might be an issue? Are they aware that they might get overclosed, or they might get TMJ issues, they might get sensitivity?
So for the older patient, Jim, or the patient with failing dentition, there may be a reorganization, there may be presentation with TMJ dysfunction, and that could be as a result of the wear, or in fact that could follow restorative procedures. That's an area that we see cases arising from.
So if you do a large amount of treatment and the patient develops TMJD, then those can be difficult claims to defend, difficult complaints to deal with when they're at the dental council, unless you've got in your records all the steps that you've taken. So as part of your assessment, have you used a FACEBO? Have you recorded the occlusion? As part of your treatment planning, have you done a wax up in liaison with your laboratory? Have you used longer term temporaries than normal? And where we see those missing from records, it can be very difficult to defend a claim, very difficult to assist a member so they get a good outcome at a dental council hearing.
Yes, we would instruct an expert to provide a report with a view of trying to find supportive experts' reports, and obviously they would look at those various factors, Jim, wouldn't they, and wish to include.
Yeah, so an expert witness's role is to provide neutral evidence to the court or to the dental council, and their evidence can be supportive, but there are times when our own experts will point out the issues with our members' cases. They'll say that they didn't even recognise that it was a reorganised occlusion, something as simple as that. And if that has resulted in TMJD, pain from the jaw joint as a result, yeah, we're going to struggle with those, aren't we?
Yeah, we are. And over the long term, when you're seeing deterioration of the dentition, there comes a point where there might be discussions about undertaking significant reorganization work, and there are obviously issues that can arise from that. We know that medications can change, patients' ability to maintain oral hygiene can change, And we have seen some cases where colleagues have been challenged due to the fact that histories and patients' situations appear not to have been taken into account when complex long-term treatments have been carried out.
Yeah, so we kind of see almost two groups here, James. Issues related to consent and capacity to consent, that as our patients get older, they're more likely to lose that capacity. They're more likely to develop dementia and kind of the affiliated sets of cognitive decline. So it's trying to ensure that when you're having discussions with patients that you take into account whether they've got that capacity to consent. And if they haven't, what have you done about it? Have you invited members of the family in? Have you provided written treatment plans? Have you delayed the start of treatment so that patients can have a long time to consider it? I have, almost tongue-in-cheek, but there's a serious point behind it, is I've said to patients where they've been contemplating large treatment plans post-retirement age, I'd like you to go home and discuss this with your children. Are they happy that you're going to be spending their inheritance? You know, if you put it in those terms, it changes the way somebody thinks about that decision. So involving the family at the outset can be really useful. The other set of issues are the general declining health, particularly polypharmacy patients, particularly dry mouths. It's worth having a review of the Chalicum scale, which is a way of assessing how dry a mouth is, and then thinking ahead. If you've got a patient with an awful lot of exposed root surfaces and you're seeing the number of medications increase, every couple of years, have you had a conversation with the patient about the risks? Have you considered potentially almost prophylactic extractions of the worst teeth? And then patients where their eyesight deteriorates, where their hand skills deteriorate, and somebody you're used to seeing with a really good oral hygiene, it suddenly falls off dramatically, and you're trying to work out what's gone wrong. The provision of high fluoride toothpaste can help in certain of those situations. High fluoride mouth rinses. Have you taken all those into account?
Indeed, and just on that, on those points, Jim, I was fortunate enough to be invited to speak at the Singapore Dental Convention, and the focus was on elderly patients and those requiring specific care. And the wonderful speakers were covering all aspects of as you've just described in detail. And one area that we spoke on, obviously the dental legal areas, and outlined a case that we'd seen where a patient who was late 70s, almost 80, unfortunately had dementia, and there was a very complicated treatment plan of many thousands of dollars, and the family were unaware of this and only got to hear about it when half of the treatment was done, and there was a significant lashback and a dental council case, and the evidence in the records that the consent process had taken place was not present, and not substantial. So the allegations were that the patient had been misled by the practitioner, treatment was unnecessary, and there'd been some dishonest behaviour, so there was significant impact on the registration of that individual. Had there been discussions with the family from the very outset, that whole situation might have been avoided. And the patient had been going to that practice for a long time, and part of the process of that patient start to lose capacity was she was a very amenable lady, always had been, and there was little perception of the fact that she was no longer of capacity because she was very agreeable going forwards, and it was all explained. And yes, there are elements of either side of that argument you could look at, but unfortunately the consequence for that clinician without records, without discussions with the rest of the family, was not good. So just a reminder, if you've said, Jim, I would totally agree, involve others, whether it be carers, whether it be siblings, all the way across, even turn it upside down, whether younger teenagers who may be of clear capacity, involve family, all round involve family if you can, and then you can avoid predisposing family members to take things further. In terms of the discussion today, we've covered some very specific areas, implants, periodontal disease in particular as the two big ticket items, and the need to record things, the informed refusal concept as well. Obviously, the long-term care of patients is involving multiple different factors, and we're just touching the surface. But by just raising the profile of the high ticket areas where we see cases and claims arising, we see colleagues struggle, knowing where you are with the patient, do they know where they are? Are we recording everything appropriately? Are things changing for that patient? And do people around that patient understand as well? And when appropriate, they should be involved. So thank you for joining us for that, Jim. And thank you, everyone, for listening to this Dental Protection podcast. If you would like more information about the topics covered today or about the speakers, please have a look in the podcast description. And if you would like a CPD certificate for listening today, please also look in the description for a link. I've been your host, James Foster, and thank you for listening.